Here's something that might surprise you. Back in 2014, doctors had over 500 different kinds of wound dressings to choose from.
Wow, 500. That's already a lot.
Right. But fast forward to today, and that number, it's jumped way up, over 900.
Over 900.
It
Goodness.
really highlights how treating a wound, something we all deal with at some point, has become much more intricate than just grabbing a bandage.
Yeah, absolutely. And what's fascinating here is that this explosion of options, it signals a real turning point in how we understand wound healing.
A turning point.
Yeah, we've moved way beyond simply covering a wound and, hoping for the best.
Exactly. And that's what we're diving into today, the modern science of wound treatment. We'll be breaking down the key ideas behind effective wound care and exploring this incredible variety of tools available now.
Yeah, many of which might be completely new to you listening.
Our discussion today draws from a deep well of medical knowledge, specifically referencing the 009 Wound Treatment Options chapter.
Right. It's based on some really solid expertise from the authors in this field. A lot of detailed work went into it.
So our goal for this deep dive is pretty simple. We want to cut through that overwhelming amount of information, all those choices,
Right.
and really focus on the core principles of modern wound care. Pinpoint what truly leads to effective healing, and maybe help you avoid some outdated practices.
Yeah, some things that maybe still linger.
Exactly. So get ready for some surprising insights into a topic that affects pretty much everyone.
Okay, so where should we start? I think looking at just how much wound care has evolved is pretty mind-blowing.
Oh yeah, how so?
Well, it's almost hard to believe, but the progress in treating wounds over the last, say, 4 decades, it actually surpasses the progress of the previous 2,000 years combined.
2,000 years.
Yeah.
Seriously, that really changes how you think about it. What was the big spark for this massive leap forward?
A major turning point really was the work of Dr. Winter back in the 1960s. His research really hammered home how crucial it is for wounds to stay moist to heal properly.
Moist, huh? Not dry.
Exactly. This was a fundamental shift. It took us away from that old idea that wounds needed to, air out and be dry.
So why? Why is keeping a wound moist so important for healing?
Okay, this is where it gets really interesting. The cells that actually do the repair work, the epithelial cells, they need moisture to move across the wound surface effectively. You can think of it like they're leapfrogging over each other to close the gap, but only if the surface is damp.
Leapfrogging, okay. Like on wet ground.
Exactly. Now picture a dry wound. In that scenario, those same cells, they have to essentially burrow down, digging around, searching for any tiny bit of moisture just so they can move.
Ah, so it slows them right down.
Way down. It's a much slower, much less efficient process. So the big takeaway here is ditch the dryness, embrace the moisture for faster cell movement, and ultimately faster healing.
That makes so much sense. Wow. And it's quite a difference from some of the historical ways people dealt with wounds, isn't it? I mean, the chapter mentions some pretty wild natural coverings.
Oh, absolutely. We're talking about things like feathers, lint, even grease, milk, wine, mud, leaves.
Mud and leaves.
Seriously.
And while these might have offered some basic protection, maybe kept dirt out,
Yeah.
they were nowhere near as helpful as the active role that modern dressings play today.
Active role. What do you mean by active? How do they actively help?
Right. So today's dressings, they do so much more than just cover the wound. They're actually designed to actively speed up healing.
Okay.
They provide a real barrier against infection, which is huge. They reduce pain, another massive consideration for patients.
Definitely.
Often they mean you don't have to change them as frequently. And get this, they can even help the body naturally clear away dead tissue. It's a process called autolytic debridement.
Autolytic debridement. So the dressing helps the body clean itself up. Precisely. And surprisingly, when you factor everything in, less frequent changes, faster healing, they can actually be more cost-effective in the long run, even if the individual dressing seems more expensive up front.
It's incredible how much things have advanced. But the chapter also brings up surprising and honestly a bit concerning point.
Yeah.
That despite all this evidence favoring moist healing, some of these older, maybe less helpful methods are still quite common.
That's right. It's quite startling, actually. The research mentioned a study over 1,600 wounds treated at home, and guess what the most common dressing used was?
Uh-oh. Let me guess.
Yeah.
Dry gauze.
Bingo, dry gauze. And even more surprisingly, the second most common approach was no dressing at all, just leaving the wound uncovered.
Wow.
And wet to dry gauze, the kind you mentioned, was also still frequently used. It really shows this disconnect between the science and what's sometimes happening in practice, especially maybe in home settings.
So why is that wet to dry gauze approach still around if it's not the best? And more importantly, you said it could actually be harmful. Why is that?
Okay, this is a crucial point. Research suggests that when you put saline moistened gauze on a wound,
Uh-huh.
as the water evaporates, the gauze basically becomes hypotonic. It gets saltier, you could say, than the tissues around it.
Right, because the water leaves, but the salt stays.
Exactly. And because nature likes balance, the body tries to dilute that saltiness by drawing fluid out of the wound and into the gauze.
Okay.
But here's the problem. That fluid isn't just water. It contains vital proteins, growth factors, all sorts of stuff essential for healing.
Oh, no.
And these substances can then form a kind of layer on the gauze, potentially blocking more moisture from reaching the wound bed. Then the really damaging part comes when the gauze dries out completely.
And you have to pull it off.
Right, and when you pull it off, it can literally rip away newly formed healthy tissue that's stuck to it.
Ouch. That sounds incredibly painful and counterproductive.
It absolutely is. It causes re-injury, pain, and ultimately it slows down the healing process significantly. It's why organizations like the World Union of Wound Healing Societies really emphasize using dressings that minimize pain and trauma during application and removal.
Which dry gauze clearly doesn't do when it sticks.
Not at all.
And what about stopping infection? I always kind of thought gauze was the standard for keeping things clean.
Yeah, that's a common misconception. But interestingly, studies have shown that gauze isn't actually a very effective barrier against bacteria,
Really?
especially when it gets damp. Bacteria can actually travel through multiple layers of dry gauze, and it's even easier for them when the gauze is moist.
So it's not really keeping germs out that well.
Not as well as you might think.
Yeah.
Compare that to wounds covered with things like transparent films or hydrocolloids. They've generally shown lower rates of infection in studies.
Okay, so it sounds like the key is keeping that moisture level just right. Like Goldilocks, not too wet, not too dry.
Exactly, you've hit the nail on the head. While moisture is essential, too much moisture can actually be harmful too.
How so?
It can damage the healthy skin surrounding the wound. You know that white, soggy-look skin gets when it's been wet for too long?
Yeah, like after a long bath.
Right. That's called maceration, and it weakens the skin, making it more prone to breakdown. So it's all about achieving that perfect balance.
So what were some of the early ways clinicians tried to get that moisture balance right, moving away from just dry gauze?
Well, film dressings, those transparent ones, and hydrocolloid dressings were some of the first materials that could really help maintain a moist environment effectively.
Okay.
But, it came with a learning curve for clinicians. They had to learn new ways to apply them, and maybe even more importantly, understand what the fluid that's sometimes collected under these dressings actually meant.
Because it might look concerning.
Exactly. That sort of light greenish-yellow fluid isn't always pus or a sign of infection. In a moist healing environment, it can actually be a normal mix of wound fluids, cells, and dressing material.
Right.
Even changes in how the wound smelled as the fluid interacted with different dressing materials took some getting used to. It wasn't always the smell they associated with infection before.
It's fascinating how much nuance there is. And
Yeah.
now we have this newer generation of dressings specifically designed to balance moisture, right? What makes them different?
That's the key word, balance. These newer dressings have a whole range of characteristics. Some are occlusive, they totally block air and moisture. Others are semi-occlusive, letting some air and moisture vapor pass through.
Okay.
Some are highly absorptive for really wet wounds. Others are designed to actually donate moisture to dry wounds. Some promote that natural debridement we talked about. And some even help stop minor bleeding.
Wow, quite the toolkit.
It really is. The point is, they're designed to help maintain that just right level of moisture, based specifically on what that individual wound needs at that particular time.
So with all these hundreds of options now, how does a doctor or even, someone taking care of a wound at home maybe make a good choice about which treatment to use?
That's the million-dollar question, isn't it? The chapter really emphasizes that good wound care comes down to a few fundamental things.
Like what?
First, really understanding the basic principles of how wounds heal. Second, carefully looking at and assessing the wound itself. What does it look like? How deep is it? Is it draining? Is there dead tissue?
Right, the assessment is key.
Absolutely. And third, having a clear idea of what you expect the outcome to be, what the goals of care are. A thorough assessment should really guide every single treatment decision.
The chapter even mentions a helpful acronym for this, right? Measures.
Yes, measures is a good framework, a good reminder of the key things to consider during assessment. But, beyond just looking at the wound, treatment decisions really need to focus on the person.
How so?
What are their goals? What are their preferences? Maybe they can't manage frequent dressing changes, or perhaps the cost is a major factor. Local wound care has to consider the whole patient, their situation, their life.
It sounds like there's definitely no single best dressing for everyone then.
Yeah. Absolutely not. It's all about matching. The right dressing needs to fit the specific characteristics of that wound and align with what you're trying to achieve.
Can you give an example?
Sure. Let's say you have a wound that's nice and pink, looks healthy. We call that granular tissue. It's moist but not draining much. Your goal there is basically to keep it that way. Maintain that moisture balance without making the skin around it soggy or letting the wound bed dry out.
Okay.
Now, contrast that with a wound that has, say, some black, hard, dead tissue eschar, and it's draining quite a bit. The goals there are totally different.
Right.
You need a dressing that can help soften that dead tissue so it can be removed, absorb all that extra fluid, and protect the healthy skin around the edges from getting macerated. Maybe something that helps with debridement, too.
That makes perfect sense. It's kind of like the chapter's really simple practical advice. If the wound is dry, add moisture. If it's draining, absorb it. If it has dead tissue, you need to get rid of it, debride it.
Exactly. Simple, but incredibly important rules of thumb.
So it's not just picking one dressing and sticking with it.
No, definitely not. And it's not a one-time decision either. Clinicians need to reassess the wound every single time they change the dressing.
Because the wound changes.
Precisely. As the wound heals, its needs change. It might start out draining heavily, needing an absorbent dressing, but as it fills in and drainage lessens, you'll likely need to switch to something different, maybe something that keeps it moist without absorbing too much.
Okay.
And it's also really, really important to actually read and understand the information that comes with the specific wound care product you're using. Not all foams are the same. Not all hydrocolloids work exactly alike. You need to know the specifics.
And you mentioned primary and secondary dressings earlier.
Yes. The primary dressing is the one that actually touches the wound bed. These are often categorized by whether they keep moisture in, soak it up, or add it.
Okay.
The secondary dressing goes on top, mainly to cover the primary one and hold it securely in place. Although, interestingly, some modern dressings available today are designed to do both jobs in one.
Like a combination dressing.
Exactly. Again, it all comes back to understanding what function you need the dressing to perform for that specific wound at that specific time.
The chapter also brings up the importance of considering the patient's overall outcome and where they're getting care, hospital versus home, for instance.
That's a really practical and important point. Using a very expensive high-tech dressing isn't helpful if a simpler, more affordable option would achieve the same goal for that patient.
Right.
And the setting matters too. In a hospital, someone might only be there for a short time. The immediate goal might not be complete healing right then and there, but maybe just ensuring the wound is clean, debrided, and kept moist to set it up for better healing later on, perhaps in home care.
Whereas at home or in long-term care, the goals might be different.
Right. The focus might be on achieving full healing over time, or maybe for some patients with complex health issues, the goal might be simply to maintain the wound, prevent infection, and manage symptoms, rather than aiming for complete closure.
And preventing infection is always a major priority, I'd imagine.
Always. It's critical. Now, it's important to remember that pretty much all open wounds will have some bacteria on them. That's normal.
Okay.
But when the number of bacteria gets too high or they start causing problems, what we might call critical colonization or infection, then using dressings that contain antimicrobial agents like silver or iodine can be really beneficial.
As an addition to antibiotics.
Yes, usually as an adjunct to systemic antibiotics if there's a true infection. But even for wounds with high bacterial load, these dressings can help. The key is to watch the wound closely. If it's not improving after a week or two, you should probably think about switching to a product that works differently.
Right, don't just keep using the same thing if it's not working. The chapter mentions a model called NICE for choosing dressings.
Yeah, it briefly mentions the NICE model, which is another framework, like measures, to help guide dressing selection, particularly thinking about infection or bioburden. It's detailed more elsewhere in the source material.
It really sounds like the old way of thinking.
Yeah.
Just slap on one type of dressing and leave it until the wound is totally healed is completely outdated.
Oh, absolutely. Wounds are dynamic. They're constantly changing environments. What they need changes over time, too.
So you need to keep checking.
Regular checkups, regular reassessment at least once a week, often more frequently depending on the wound, are essential to guide those ongoing dressing choices. As the wound moves through the different phases of healing, you'll almost certainly need to use different types of products to support it optimally.
Okay, let's maybe get into some specific examples then. How do you match dressings to the wound? What about those really deep wounds that are, like, draining a lot?
Yeah, for those kinds of wounds, deep, maybe tunneling, lots of exudate or drainage, you need something highly absorbent. Dressings like calcium alginates or foam dressings are usually the go-to choice there. They can really soak up a lot of fluid and help manage all that drainage.
Okay, alginates and foams for heavy drainage. And then, as things hopefully improve, the drainage starts to lessen, and you start seeing that healthy pink tissue granulation and maybe new skin forming around the edges.
What then?
Right, as the wound progresses and becomes less wet, you'll want to switch gears. You'd move towards dressings that don't absorb as much but are good at maintaining that crucial moist balance. Think about things like hydrogels, maybe hydrocolloids, or even transparent film dressings, depending on how much moisture is needed.
Got it. The chapter also brings up cost, which we touched on. Not just the sticker price of the dressing, but also nursing time, how often it needs changing.
These are definitely critical factors, especially from a healthcare system perspective, but also for the patient. It's about the overall cost of care, not just the cost per dressing.
Right. Sometimes a dressing that seems more expensive initially might actually save money in the long run if it needs changing less often, requires less nursing time, and most importantly, helps the wound heal faster, preventing complications. There's actually a table 9 to 4 in the chapter, that delves into some of these economic considerations.
And it's not just about what the wound looks like, but also why the person has the wound in the first place, right?
Yeah.
Its underlying cause.
Absolutely critical. Knowing the etiology, the cause of the wound, is essential for effective treatment. You can have the best dressing in the world, but if you're not addressing the underlying problem, the wound might not heal.
Like the example you gave earlier.
Exactly.
Yeah.
Take a venous stasis ulcer, common on the lower leg, caused by poor blood flow back up the veins. These often drain a lot, so you need an absorptive dressing. But just putting on a dressing isn't enough. You must also use compression therapy, special bandages, or stockings to help improve that venous return.
So the dressing handles the wound, the compression handles the cause.
Precisely. And there are many different kinds of compression bandages and systems available now. Similarly, for ulcers caused by poor arterial blood flow or diabetic nerve damage, it's crucial to assess the circulation in the legs and feet, things like the ankle brachial index, before deciding on treatment, especially compression.
It's amazing how our deeper understanding of the actual biology of wound healing is also leading to new treatment options. The chapter briefly mentions things like growth factors.
Yes, definitely. As we've learned more about the complex cascade of cells and signaling molecules involved in the healing process, it's opened up some really exciting therapeutic possibilities. Growth factors are a key example.
What are they exactly?
They're basically proteins that act as signals, telling cells to divide, migrate, and produce other important components needed for repair. They can be derived from a person's own blood, like platelets, or manufactured using recombinant DNA technology.
And how are they used?
They can be applied directly to the wound, usually as a gel, to try and stimulate healing, especially in wounds that seem stalled. Researchers are still figuring out the optimal ways to use them, which growth factors are best for which wounds, and so on.
And what about those tissue-engineered skin substitutes? That sounds very futuristic.
It does, doesn't it? But it's another area where technology is offering new tools for difficult-to-heal wounds. These are essentially lab-grown skin equivalents or substitutes, sometimes containing living cells, that can be applied to the wound to provide a scaffold and stimulate the body's own healing processes.
Wow.
And looking even further ahead, scientists are exploring the potential of gene therapy to influence wound healing, although that's still mostly in the research stages right now.
Okay, this is fascinating. Let's maybe dive into the specifics of some of these main dressing categories you've mentioned, starting with those see-through film dressings. What are the key things to know about them?
Right, transparent film dressings. They're very thin sheets, usually polyurethane, and they typically only have adhesive around the very edges so the main part doesn't stick to the wound itself.
Okay, non-stick center.
Exactly. They don't really soak up any fluid to speak of, but they are permeable to moisture vapor. They let water vapor escape, and also to gases like oxygen and carbon dioxide, so they're semi-permeable.
And they create that moist environment you talked about.
Yes, they trap the wound's natural moisture, creating an environment kind of like what you see under a blister.
Yeah.
And that moist environment, as we discussed, really helps those skin cells migrate and repair the wound. It also encourages that autolytic debridement, the body's natural cleanup process.
So the fluid underneath isn't always bad.
Correct. Some fluid collecting underneath is often normal and part of the healing process. It's not automatically pus or infection. These films also act as a barrier to outside contaminants and bacteria, and they protect the wound from friction. They can also be used as a secondary dressing over something else, like a hydrogel.
And what kind of wounds are they best suited for?
They work best for wounds that have very little or no drainage. Think superficial pressure injuries, minor bruins or cuts, covering stitches or IV catheter sites, or covering the site where skin was taken for a graft. They can usually stay on for up to a week.
Any downsides or things to watch out for?
Yeah, you need to be cautious using them on very fragile skin, like in elderly patients, as the adhesive edges can sometimes cause damage on removal. They're generally not the best choice for skin tears for that reason, or for any wound that's draining more than just a tiny amount because the fluid will just pool underneath.
Got it. Okay, what about hydrocolloid dressings? You mentioned those were early pioneers in moist wound healing.
Yes, hydrocolloids were very widely used for many years and are still valuable. Unlike films, they are impermeable. They don't let gases or water vapor pass through easily. They have an adhesive backing and contain absorbent particles, often things like pectin or sodium carboxymethylcellulose.
And how do they work?
They interact with the wound exudate, the fluid coming from the wound, and they absorb it to form a soft, moist gel right over the wound bed. This gel helps maintain that moist environment.
I think I remember those sometimes having a particular smell when removed.
Yes, that's quite characteristic. As the dressing interacts with the wound fluid, it can produce a distinct, often described as wound-like or slightly unpleasant odor when you change it. That's usually normal for hydrocolloids and not necessarily a sign of infection. They can also sometimes leave a yellowish gel-like residue in the wound, which should just be gently rinsed away.
Okay. And what are they typically used for?
They're good for wounds with minimal to moderate amounts of exudate. Think abrasions, pressure injuries, dermal ulcers, wounds that are granulating nicely, and even some wounds with necrotic tissue, as the moist environment helps soften it. Because they don't absorb fluid super quickly, they can be useful as drainage decreases.
Can they be used for prevention?
Yes, they're quite good for protecting high-risk areas, like the sacrum or heels, from friction and pressure, and sometimes used over surgical sites to prevent blistering or skin breakdown. However, because they form that gel, they're generally not recommended for wounds that have deep tunnels or undermining where the gel could get trapped.
Right, that makes sense. Moving on to hydrogel dressings. The name suggests water, so are they about adding moisture?
Exactly. Hydrogels are primarily about hydration. They have a very high water content, often held within polymer matrices, making them feel like a gel. They come in different forms, amorphous gels you can squeeze from a tube, solid sheets, or gauze impregnated with the gel.
So for dry wounds.
Precisely. They're excellent for donating moisture to dry wound beds, softening dry slough or eschar, making it easier to remove. They can also feel quite cooling and soothing on the wound, which can help with pain.
Do they absorb much?
Generally, no. Their main job is hydration, not absorption. Although some newer formulations might have added components like alginates or collagen to give them some capacity to handle low to moderate exudate.
And where would you typically use a hydrogel?
Think dry or minimally draining pressure injuries, wounds going through part or all skin layers, vascular ulcers that are dry, skin tears, areas where the top skin layer is scraped off, dermabrasion, donor sites, and even radiation burns.
Anything to be careful about?
Because they're so hydrating, you need to be careful not to get too much gel on the surrounding healthy skin, as it could cause maceration. You might need a secondary dressing to hold them in place. Also, while you can often use them with topical medications, hydrogels containing silver generally shouldn't be mixed with enzymatic debriding agents, as the silver can deactivate the enzymes, and definitely not for heavily draining wounds.
Okay. Now this one's intriguing honey as a wound dressing.
Yes, it sounds traditional, but we're talking about specific medical-grade honey here, usually active leptospermum or manuka honey, which is sterilized and prepared specifically for wound care.
And it has special properties.
It does. It's known to help reduce edema or swelling. It can lower the pH of the wound surface, which can inhibit some bacteria. And it also promotes that natural autolytic debridement process, helping to lift dead tissue.
Interesting. So when would you consider using a honey dressing?
They're indicated for a pretty wide range of wounds, including those that are infected or heavily colonized with bacteria, wounds with slough or necrosis, partial and full thickness wounds, and chronic wounds like venous or diabetic ulcers. They come in various forms: gels, sheets, impregnated
Any
dressings.
contraindications?
The main one is an allergy to honey or bee products, obviously. Some people report a temporary stinging sensation when it's first applied,
Okay.
and they usually require secondary dressing to keep them in place and manage any drainage.
Okay, let's talk foam dressings. These sound like the heavy hitters for absorption.
That's a good way to put it. Foam dressings are typically made from hydrophilic polyurethane, meaning it loves water, so they're highly absorbent. They also allow gases and water vapor to pass through, so they're breathable. Their structure, often layered, allows them to wick fluid away from the wound bed and hold onto it.
So for moderate to heavy drainage.
Exactly. They're a mainstay for managing moderate to heavy exudate in various wound types: partial and full thickness wounds, granulating wounds, skin tears, donor sites. They're also commonly used under compression bandages because they can handle the fluid. Plus, their cushioning effect makes them good for prophylactic padding over bony prominences or areas prone to friction.
Can they be used if a wound is infected?
Yes, they can generally be used on infected wounds, although the wear time might be shorter, maybe 3 to 5 days or until saturated. Many foam dressings also come with added silver for an antimicrobial effect.
Just see.
Some have an adhesive border, while others are non-adhesive and require a secondary dressing or tape to hold them in place. There are even special shapes, like sacral foams designed to fit the tailbone area, often used for pressure injury prevention. They're generally known for being relatively trauma-free on removal.
What about calcium alginate dressings? You mentioned they come from seaweed.
That's right, brown seaweed.
Yeah.
The fibers are processed to create these highly absorbent dressings. They're non-adherent and biodegradable.
And how do they work with wound fluid?
When the calcium alginate fibers come into contact with wound exudate, which is rich in sodium, an ion exchange happens. The dressing absorbs the sodium-rich fluid and releases calcium ions, transforming the dry fibers into a soft, hydrophilic sodium alginate gel right within the wound bed. This gel maintains a moist environment while absorbing large amounts of fluid.
So really for the wettest wounds.
Exactly. They are excellent choices for heavily draining wounds. Things like deep pressure injuries, vascular ulcers, surgical wounds that have opened up dehiscence, wounds with tunnels or sinus tracts. They can also be used on infected wounds and can help control minor bleeding due to the calcium ion release.
When wouldn't you use them?
They're contraindicated for dry wounds or wounds covered in dry, hard eschar because they need moisture to activate and form the gel. Also, not for third-degree burns. They almost always require secondary dressing and often need changing daily, especially initially.
And that gel formation is normal.
Yes, the gel formation is the intended action. It might leave some fiber residue in the wound, which should just be gently flushed out with saline during dressing changes. That moist gel environment also helps facilitate autolytic debridement. Some alginates also contain silver.
Okay, composite dressings, the name suggests they're a mix of things.
Precisely. They're like a multi-tool of dressings. They're multi-layered, combining different components into one dressing. Maybe a non-adherent contact layer, an absorptive layer, foam, maybe even hydrocolloid or hydrogel components, often with an adhesive border.
So kind of an all-in-one.
Sort of. They aim to provide a bacterial barrier, absorption, and protection in one package. They're generally conformable. However, not all composites necessarily maintain a moist environment. Some might just be absorptive pads with an adhesive border.
When might you use one?
They can be convenient for certain wounds, sometimes used on infected wounds or with topical agents. Change frequency varies a lot depending on the specific product and the amount of drainage. A potential downside is that the adhesive border might sometimes adhere too strongly, especially on fragile skin.
Now, collagen dressings. The chapter mentions these are particularly for wounds that seem stalled.
Yes, that's a key indication. Collagen is the main structural protein in our skin and tissues, absolutely vital for wound healing. Sometimes, in chronic wounds that are stuck in an inflammatory phase, the body's own collagen gets broken down too quickly by enzymes called MMPs.
So these dressings add collagen back.
Exactly. They provide a source of collagen to the wound bed, which can help support a moist healing environment, encourage the body to lay down new collagen, and promote the growth of healthy granulation tissue. They're derived from various animal sources: bovine, porcine, equine, etc.
How do you choose the form?
They come in different forms depending on the wound's needs. Powders, particles, or pads are usually highly absorptive and good for wounds with high exudate. Sheets might be better for low to moderate exudate, and gels can be used for drier wounds needing some moisture plus the collagen benefit.
What wounds are they used for?
Generally for granulating or necrotic wounds, partial or full thickness wounds that aren't progressing as expected. They typically need a secondary dressing and might be changed every 1 to 3 days. They work best when placed on tissue that's already starting to granulate. They shouldn't be used if someone has sensitivities to the animal source, on dry eschar, or third-degree burns.
Contact layer dressings, you mentioned these earlier. Their main job is just preventing sticking.
Pretty much. They're usually a single layer of woven or knitted material, like a mesh or net, designed to be very low adherence. They sit directly on the wound bed, acting as an interface between the wound and whatever secondary absorptive dressing you put on top.
So fluid passes through.
Yes, the pores allow exudate to pass through freely to the overlying dressing. This means you can change the secondary dressing as often as needed without disturbing or sticking to the delicate wound bed underneath. They can often stay in place for several days, reducing trauma and pain associated with dressing changes. They're often used with ointments or creams applied directly to the wound.
Okay. Antimicrobial dressings seem like a really important category, especially with concerns about infection.
Absolutely. These dressings combine the function of providing a moist environment with an active antimicrobial effect to reduce the bacterial load in the wound. They contain agents like silver ions, cadexomer iodine, medical-grade honey, or PHMB.
And they're used for infected wounds.
Yes, they're often used as an adjunct to systemic antibiotics for clinically infected wounds or for wounds that are heavily colonized and at high risk of infection. They come in various forms: foams, alginates, hydrofibers, contact layers, gels. Some provide sustained release of the antimicrobial over several days.
Silver seems common.
Silver dressings are very widely used. How they work depends on the specific product. Some release silver ions into the wound bed when they get moist. Others bind bacteria to the dressing. It's important to know that silver can sometimes cause temporary, harmless staining of the skin. Also, silver dressings usually need to be removed before MRI scans or radiation therapy, and again, generally shouldn't be used with enzymatic debriders.
And finally, absorptive dressings. Is this just a general category for anything that soaks up fluid?
Kind of. While many dressings like foams and alginates are absorptive, this category sometimes refers specifically to simpler multi-layer pads designed primarily for absorption. They might have a non-adherent or semi-adherent contact layer, and then layers of absorbent fibers like cellulose, cotton, or rayon inside. Some might form a gel when they absorb exudate. Their main job is to manage moderate to heavy drainage and minimize adherence. You just need to monitor them to ensure you change them frequently enough to prevent maceration of the surrounding skin.
Wow. That's a lot of different types. It really
Yeah.
drives home how specific wound care needs to be. Now, the chapter then shifts gears a bit, moving on to more advanced therapies for wounds that just aren't getting better with this kind of standard care.
Yes, exactly. These are therapies generally considered when a wound hasn't shown significant signs of improvement after about 4 weeks of good, basic wound care using appropriate dressings and addressing underlying issues.
And they fall into different categories.
Right. The chapter groups them into 3 main types: mechanical therapies, biological therapies, and pharmaceutical therapies. They're not usually the first line of attack, but they're important tools used according to specific guidelines and algorithms, often aimed at boosting things like blood vessel growth or improving tissue perfusion.
Okay, let's start with the mechanical ones. Negative pressure wound therapy, or NPWT. That's probably one that many people listening might have actually heard of or even seen.
Yes, NPWT, sometimes called vacuum-assisted closure or VAC therapy, has become a very common and important treatment for many types of chronic and complex acute wounds over the last couple of decades.
How does it work?
It involves applying controlled subatmospheric pressure, basically, gentle suction evenly across the wound bed. This is done using a specialized pump connected via tubing to a wound dressing that seals over the wound. The interface between the wound and the tubing is usually a special foam or sometimes gauze.
And what does that suction actually do for the wound?
It has several beneficial effects. It helps draw the wound edges together, promoting contraction. It removes excess fluid or edema and infectious material from the wound, which can improve blood flow and reduce bacterial load. It also stimulates the formation of healthy granulation tissue.
How does it stimulate tissue growth? That seems amazing.
There are a couple of theories. One is macrostrain, the visible shrinking and drawing together of the wound. The other is microstrain, the idea that the negative pressure creates tiny mechanical forces at the cellular level, stretching the cells and triggering them to proliferate, produce growth factors, and lay down more extracellular matrix, basically stimulating them to build new tissue and blood vessels.
Fascinating. It sounds really effective.
Yeah.
Are there any critical things to keep in mind when using NPWT?
Definitely. First, it's generally recommended to remove any significant amount of necrotic tissue to debride the wound before starting NPWT. The exact amount varies by protocol, but you want a relatively clean base. Also, caution is needed if there's active bleeding, if the patient is on anticoagulants, or if the dressing is near exposed blood vessels or organs, as the suction could potentially cause problems. It's absolutely not a substitute for surgical debridement when that's needed, and it's crucial that all the dressing materials, the foam or gauze, are carefully removed during each dressing change. You don't want anything left behind. Skin protection around the wound is also important to prevent damage from the adhesive drape.
Makes sense. Okay, compression therapy is another mechanical approach. You mentioned it earlier for venous ulcers, specifically related to swelling.
Absolutely. Compression therapy is really the cornerstone, the foundation for managing wounds associated with edema, particularly venous insufficiency, but also lymphedema. The goal of compression wraps or garments is to provide external pressure to help manage the fluid buildup and promote the return of venous blood and lymphatic fluid back towards the heart.
Is the fluid different in lymphedema?
Yes, the fluid in lymphedema tends to be more protein-rich and viscous, thicker than the edema typically seen in venous insufficiency. Because of this, lymphedema often requires higher levels of compression, usually with inelastic or short-stretch bandages, which provide very firm resistance against muscle movement.
Short stretch versus long stretch. What's the difference?
Short-stretch bandages, like the kind used in an Una boot perhaps, have very little elasticity. They provide high pressure when the calf muscles contract during walking, high working pressure, but relatively low pressure when the leg is at rest, low resting pressure. This milking action is great for pumping fluid out in active patients with venous issues or lymphedema.
Okay.
Long stretch bandages, like common elastic bandages, stretch a lot more. They provide more constant pressure, higher at rest but lower during activity. They might be better suited for patients who are less mobile. For venous reflux, that high working pressure of the inelastic systems is generally considered more effective.
It sounds like applying them correctly is important.
Critically important. Unfortunately, studies have shown that many healthcare professionals lack adequate knowledge or training in proper compression application techniques. It really needs to be done according to the manufacturer's instructions and specific protocols to achieve the right pressure levels without causing harm. There are also newer compression systems like multi-layer wraps, Velcro strap garments, and sock systems designed to make correct application easier.
And what about intermittent pneumatic compression, IPC? That sounds like a machine does the work.
It does. IPC devices use inflatable sleeves or boots with multiple chambers that inflate and deflate sequentially, moving up the limb. This helps squeeze blood out of the superficial veins into the deeper system and increases tissue pressure.
What are the benefits?
It can improve circulation, boost oxygen delivery, help remove waste products, and even enhance the body's natural clot-busting activity. It's often used for venous ulcers, usually while the patient is lying down with their leg elevated.
Are there times you wouldn't use it?
Yes, contraindications include acute deep vein thrombosis, DVT, or severe peripheral artery disease, PAD. Caution is also needed with congestive heart failure or lymphedema. As always, a thorough vascular assessment, including checking the ABI, is crucial before applying any significant compression, especially if there might be mixed venous and arterial disease. Interestingly, there's also a type of arterial compression therapy that uses pneumatic devices specifically designed to improve blood flow in the arteries for patients with arterial disease.
Okay, the third type of mechanical therapy is energy-based therapy. This includes things like electrical stimulation, light therapy, and ultrasound. Sounds pretty high-tech.
It is. These therapies use different forms of physical energy, electrical, light, or sound to try and stimulate or augment the body's natural healing responses at the cellular level. They should always be used in addition to, not instead of, good standard wound care like maintaining moisture and debridement. And they generally require a skilled, licensed professional to administer them.
Let's start with electrical stimulation, or ES. How does electricity help heal a wound?
Well, the body actually has its own natural electrical currents involved in injury and repair. ES therapy uses externally applied, very small electrical currents to try and mimic or enhance these natural signals, potentially restarting the healing process in chronic wounds that have stalled.
What effects does it have?
Research suggests ES can increase blood flow and oxygen levels in the area, stimulate the growth of new blood vessels, angiogenesis, promote collagen production, encourage wound contraction and skin cell migration, epithelialization, and maybe even reduce wound pain or neuropathic pain.
How is it applied?
Usually via electrodes placed directly in or around the wound bed, sometimes using special conductive garments like socks or gloves. There are different types of currents used, with high voltage pulsed current, HVPC, being one of the most common for wound care. The parameters intensity, polarity, frequency are adjusted by the trained therapist based on the wound and treatment goals.
Any reason not to use it?
Yes, contraindications typically include malignancy in the wound area, untreated osteomyelitis, bone infection, and caution is needed near electronic implants like pacemakers or over certain areas like the carotid sinus or heart. It's thought to work partly by attracting different cell types, like neutrophils and fibroblasts, to the wound area through a process called galvanotaxis.
Okay, what about light therapy? I've heard of low-level laser therapy.
Yes, light therapy or phototherapy involves using specific wavelengths of light. Low-level laser therapy, LLLT, sometimes called photobiomodulation or cold laser, uses low-intensity laser or LED light, usually in the red or near infrared spectrum. Unlike surgical lasers, it doesn't generate heat.
And what's the goal?
The goal is tissue regeneration. It's thought to have positive effects on inflammation, cell proliferation, and tissue remodeling, potentially speeding up healing. Studies suggest it can reduce inflammation, promote earlier cell growth, enhance contraction and blood vessel formation. There's research on its use for various chronic wounds, soft tissue injuries, nerve regeneration, and even post-op pain relief.
How is it applied?
Usually with a handheld probe or a pad containing multiple diodes placed gently on or near the wound, often with a thin barrier over an open wound.
Is ultraviolet light also used?
Yes, UV light is another form. UVA and UVB have effects on skin pigmentation and can stimulate some tissue growth. UVC light, which has shorter wavelengths, is primarily used for its bactericidal effects. It's known to kill bacteria, including resistant strains like MRSA, at least in lab studies and some clinical reports. The idea is to reduce the bacterial burden in chronic wounds. However, you have to balance the benefit against the potential for UV light, especially UVC and UVB, to damage healthy host cells. Modern equipment has safeguards like distance guards.
And the last energy-based one, ultrasonic energy. I know ultrasound is used for imaging.
Right. Diagnostic ultrasound uses high frequencies. For therapeutic purposes in wound care, we typically use low-frequency ultrasound, or LFU, usually in the 120 kilohertz range.
And what does LFU do?
LFU has several proposed benefits. It can help debride necrotic tissue, kill certain bacteria, and stimulate healing processes. The mechanisms are thought to involve cavitation, the formation and implosion of microscopic bubbles in fluids, and acoustic streaming, the movement of fluids caused by the sound waves.
How does cavitation help?
The energy released when those tiny bubbles implode is thought to help break down dead tissue and bacterial cell walls. Acoustic streaming might alter cell membrane permeability, potentially increasing the uptake of beneficial substances or stimulating cell activity like fibroblast proliferation and growth factor release.
Are there different ways to deliver LFU?
Yes, there's contact and non-contact LFU. Contact devices use a probe tip that directly touches the wound bed, usually with a sterile saline solution as a coupling medium. This provides both mechanical debridement and cellular stimulation. Non-contact LFU devices deliver the ultrasound energy through a mist of saline, primarily aiming to stimulate the cells and reduce bioburden without physically scraping the wound. Examples include MES therapy. Contact devices, often called ultrasonic guided debridement, UGD, offer more precise selective debridement, potentially preserving healthy tissue while removing non-viable tissue and killing bacteria simultaneously. However, contact UGD requires significant clinician skill and careful pain management.
Any precautions for ultrasound?
Similar to ES, caution is needed near electronic implants, over malignancies, or during pregnancy near the lower back or abdomen. A unique aspect of contact UGD is its reported ability to kill bacteria during the debridement process itself.
Okay, that covers the mechanical therapies. Let's move into the biological therapies. The chapter mentions cellular and tissue-based products, or CTPs. That sounds complex.
It is a complex and rapidly evolving area. CTPs basically encompass a range of products derived from living cells or tissues designed to actively promote healing in chronic wounds that aren't responding to other treatments. Think of them as bioactive materials, biosynthetic matrices, or biopharmaceuticals.
Bioactive materials from human tissue. What does that include?
This category includes things like cultured living allografts, basically engineered skin substitutes grown in a lab, often containing living skin cells, keratinocytes, and fibroblasts, on a biodegradable scaffold. Aplograft and dermagraft are well-known examples.
Skin substitutes.
Also included are human amnion chorion membrane allografts derived from placental tissue after C-sections. These membranes are rich in growth factors and have shown great promise in burn care and now chronic wound healing, reducing inflammation and scarring. Then there are epidermal grafts, where a very thin layer of the patient's own epidermis is harvested, maybe using suction blistering, and transferred to the wound. And finally, acellular dermal matrices, which are scaffolds derived from human dermis with the cells removed.
What's key when using these?
Meticulous wound bed preparation is absolutely paramount. The wound needs to be clean, free of infection, and have adequate blood supply for these grafts to take. And careful protection and monitoring after application are crucial. Also, aggressive offloading is essential if these are used on plantar foot wounds.
Do they fully replicate normal skin?
That's an important point. No biological material available currently fully replicates all the structures and functions of normal, healthy skin. They act as scaffolds or deliver key cell factors to kickstart healing.
Okay, what about biosynthetic matrices and xenografts? Those sound like they're not from human sources.
Correct. Xenografts come from non-human animal tissues, usually bovine, cow, or porcine, pig. Biosynthetic matrices might be synthetic or animal-derived. These tissues are processed to remove the cells, decellularize, but preserve the extracellular matrix, the collagen scaffold.
So they provide a framework.
Exactly. They act as a bioresorbable scaffold that the patient's own cells can infiltrate and use as a template for rebuilding tissue. They're used for various partial and full-thickness wounds, and studies have shown improved healing compared to standard care alone in some cases, like venous ulcers treated with certain xenografts plus compression.
And biopharmaceuticals. That sounds like medication again.
It is, but these are typically large molecule products derived from biological sources, not chemically synthesized small molecules.
Yeah.
Examples in general medicine include vaccines or blood products. In wound care, the main examples are growth factors.
Like the ones you mentioned earlier.
Yes. One specific example is the Kaplan gel, Regranex, which is a recombinant human platelet-derived growth factor, PDGF. It's a prescription medication specifically approved for treating certain types of diabetic foot ulcers.
Is it widely used?
It can be effective, but there have been some safety concerns raised in post-marketing studies regarding a potential increased risk of mortality due to malignancy with prolonged or expensive use, like using more than 3 tubes. So it's generally used cautiously when the potential benefits are felt to outweigh the risks and avoided if there's a known malignancy. It also needs refrigeration.
Okay. What about platelet-rich plasma, PRP?
PRP is another way to deliver growth factors. It involves drawing the patient's own blood, centrifuging it right there at the point of care to concentrate the platelets, which are rich in multiple growth factors, and then applying this platelet concentrate, often as a gel, directly to the prepared wound bed.
And biotechnologies, that's the really cutting-edge stuff.
Yes, this category includes things like gene therapy approaches or stem cell therapies aimed at wound healing. These are mostly still in research protocols with limited routine clinical use currently. Stem cell therapy involves delivering stem cells, often harvested from the patient's own bone marrow, fat, or blood, to the wound, hoping they will differentiate into needed cell types or release factors that promote healing. Early studies show some promise.
Fascinating. The last major category is pharmaceutical, and the chapter focuses specifically on oxygen therapy here.
Right. When oxygen is administered specifically for therapeutic wound healing purposes, it's considered a pharmaceutical agent, usually requiring a prescription or specific protocol. The main types discussed are hyperbaric oxygen therapy, HBOT, and topical or transdermal oxygen.
Let's talk about HBOT first. That involves a pressurized chamber.
Exactly. Hyperbaric oxygen therapy involves the patient breathing 100% oxygen while inside a chamber pressurized to greater than normal atmospheric pressure, usually 1.5 to 3 times normal sea level pressure. This can be a large multi-place chamber treating several patients at once, or a smaller monoplace chamber for a single patient.
What's the point of the pressure?
The combination of breathing pure oxygen and being under increased pressure dramatically increases the amount of oxygen dissolved directly into the blood plasma. Normally, most oxygen is carried by hemoglobin in red blood cells, but under HBOT conditions, the plasma itself becomes saturated with oxygen, reaching levels far higher than possible just by breathing oxygen at normal pressure.
And that extra oxygen gets to the tissues.
Yes, it creates a very steep gradient, driving oxygen much deeper into tissues, especially those with poor blood supply, ischemic tissues. This tissue hyperoxygenation has several benefits.
Such
It directly corrects tissue hypoxia. It stimulates angiogenesis, the growth of new blood vessels. It can cause temporary vasoconstriction, which paradoxically helps reduce edema and crush injuries. It supports the metabolic activity of wound healing cells like fibroblasts. It upregulates important growth factors. It enhances the ability of white blood cells to kill bacteria, both aerobic and anaerobic. And it can have antioxidant effects, limiting damage from ischemia reperfusion injury.
So it's quite powerful. What kinds of wounds or conditions is HBOT typically used for?
There's a list of approved or generally accepted indications established by expert consensus groups like the Undersea and Hyperbaric Medical Society, UHMS. These include things like air or gas embolism, carbon monoxide poisoning, gas gangrene, crush injuries, decompression sickness, the bends, certain arterial insufficiencies where it can enhance healing, central retinal artery occlusion, severe anemia, necrotizing soft tissue infections, flesh-eating bacteria, refractory osteomyelitis, bone infection that doesn't respond to other treatments, delayed radiation injury, compromised skin grafts or flaps, and acute thermal burns.
That's quite a list. Are there specific considerations?
Yes. HBOT is a medical treatment that needs to be prescribed and supervised by a physician specifically trained and certified in hyperbaric medicine. There are potential side effects, mainly related to pressure changes, barotrauma affecting ears or sinuses, and rarely oxygen toxicity if protocols aren't followed. Blood glucose levels also need careful monitoring in patients with diabetes, as HBOT can sometimes cause a rapid drop.
So it's an adjunct therapy.
Absolutely. It's almost always used in addition to other necessary treatments like surgery, antibiotics, debridement, and good wound care. For arterial insufficiency wounds, for example, aggressive vascular evaluation and revascularization attempts should usually come first. Patient selection is key. But for the right patient, HBOT can be a powerful tool to enhance healing and potentially save limbs.
The chapter also mentions transdermal or topical oxygen therapy. How is that different?
Topical oxygen involves delivering oxygen directly to the wound surface, historically sometimes by enclosing a limb in an oxygen-filled bag or box. Newer devices might use special dressings that continuously release oxygen onto the wound bed.
Is it like HBOT but just local?
Not really. It's sometimes incorrectly called topical hyperbaric oxygen, but it doesn't involve increased pressure. The idea is that while intact skin is a barrier to atmospheric oxygen, an open wound might allow direct diffusion of oxygen into the superficial tissues. Proponents suggest it can be bacteriostatic and stimulate local healing. Novel devices, like dressings with small oxygen reservoirs, aim to provide a continuous supply for several days. Some studies, like one on burn donor sites, have shown potential benefits like faster healing and reduced pain.
It's widely accepted.
The overall role and efficacy of topical oxygen therapy are still debated, and concerns about cost-effectiveness and overutilization exist. More research is needed on these alternative delivery systems.
Okay, one last important area the chapter covers before wrapping up is scar management. That's definitely something people worry about after a wound heals.
Absolutely. Preventing excessive or problematic scarring is a major concern for patients and clinicians alike. We've made progress in understanding why some wounds lead to exaggerated scars, like hypertrophic scars or keloids.
What are the key principles for managing scars?
Generally, good scar management focuses on providing support to the healing tissue, controlling inflammation during the healing process, ensuring adequate hydration of the scar tissue, and promoting proper collagen remodeling and maturation as the scar settles down. There's even an acronym, SCAR, mentioned in a table, outlining some principles.
Are there specific treatments?
Yes, scar control often relies on a combination approach. Things like silicone gel sheeting or liquid silicone gels are very common. Sometimes pressure garments are used, especially after burns. The chapter describes one patented process involving a specific cream gel applied under microporous tape, which acts as an occlusive dressing, allowing the agents to penetrate the scar. This process, used consistently, showed good results in preventing hypertrophic scars in a trial.
What about keloid scars? Are they different?
Yes, very different. It's crucial to distinguish between a hypertrophic scar, which is raised and perhaps red but stays within the boundaries of the original wound, and a keloid scar. Keloids are almost like benign tumors of scar tissue. They grow uncontrollably beyond the original wound boundaries, can be painful or itchy, and are often linked to a genetic predisposition. They are much harder to treat, and standard scar management techniques often don't work well. Treatments like radiotherapy might be used, but outcomes are unpredictable.
So our principles don't apply to keloids.
Generally not in the same way. The underlying mechanisms are different, so they require different management strategies.
This has been such a comprehensive deep dive into the vast world of modern wound treatment options. The sheer number of choices and the science behind them is really quite amazing.
It is, and I think the most important takeaway, the thread running through all of this, is that wound care needs to be patient-centered and driven by clear goals.
Right.
While the abundance of dressing choices can seem daunting, going back to those core principles, maintaining appropriate moisture, careful assessment, understanding the wound's characteristics and cause, and matching the treatment to those needs is absolutely essential.
And recognizing when standard care isn't enough and considering these advanced therapies.
Exactly. Those therapies, NPWT, compression, energy-based treatments, biologicals, HBOT, are incredibly important tools in the armamentarium for complex or stalled wounds. The chapter provides helpful tables, figures, and those practice points throughout to guide clinicians.
It's also striking, though, how you mentioned that even with all these advancements, some older, less effective, even potentially harmful methods like wet-to-dry gauze are still sometimes used.
That's true, and it highlights the ongoing need for education and adherence to evidence-based practices.
So for you listening, understanding these principles, moist healing, proper assessment, matching treatment to the wound, can really empower you to have more informed conversations about wound care, whether it's for yourself or perhaps someone you're caring for.
Definitely. And it leads to a final thought, maybe something for you to ponder. With all this continuous progress and innovation happening in wound care science and technology, what future developments do you think will have the most significant impact on how we heal wounds and improve patient outcomes down the road?
That's a great question to leave people with. It's certainly a field that's not standing still.